We appreciate your participation in today's webinar. My name is Corleen Vaverka. I'm the Director of Operations at Glycare. Today, we will discuss how Glycare supports facilities in enhancing their diabetes care programs. I'll introduce our speakers here in just a moment, but first, if you have any questions during the webinar, please use the Q&A window, and then we'll address them during the presentation. We'll also leave some time for Q&A, so if your questions weren't addressed in that chat, we'll be sure to address them at that time. The webinar is actually recorded, and you're going to receive a copy of this deck as well as the webinar. It will be emailed after we conclude. You'll also be asked to complete a very brief 2-question survey. So we hope you learn new things and have a great session with us. And with that, let me introduce you to our speakers. Okay, today's speakers are Dr. David Sutton, board certified endocrinologist and Glycare co-founder. Dr. Gary Evans, board certified clinical endocrinologist and Glycare co-founder. And Dr. Guillermo Perez, he is also board certified clinical endocrinologist and serves on Glycare's medical advisory board. He is also the former 2022 president of the American Diabetes Association. With that, let me pass it over to Dr. Perez.
Thank you, Corleen. So the agenda for today is first to go over the state of diabetes care in the hospital, discuss the economic impact on the healthcare system, and talk to you about Glycare, how it supports healthcare facility, enhancing the care of diabetes in hospitalized patients. And we will present later Glycare's clinical outcomes. Next. And I would like to start, next slide, please. I would like to start with the recent report from the Center for Disease Control highlighting the epidemic of diabetes in the United States. It is amazing, impressive that during the past 20 years, the number of adults with diabetes have more than doubled. In the year 2004, there were somewhere around 18 million, or 6.3% of the population has diabetes. In November last year, the Center for Disease Control reported 38.4 million people, or 11.6% of Americans with diabetes. During the same period, the last 20 years, shown to the right, we also learned that patients with diabetes are likely to be admitted more than patients without diabetes, and they have higher rate of complications. From the year 2000 to 2018, the proportion of patients with the primary diagnosis of diabetes went up from 17.1% to 27%. But it's not only the number of people in the hospital. There's also more than 17 million persons goes to the emergency room with the primary diagnosis of diabetes, and the elevated cost over 300 billion people annual cost for diabetes care. So no question, we are in the middle of an epidemic of diabetes. Next slide. Our group and others have reported that 1 in 3 patients who are admitted to the hospital, general medicine, or ICU have hyperglycemia, and somewhere around 28% have a diagnosis of diabetes. Hyperglycemia in patients with and without diabetes are associated with increased rate of complications, higher mortality, higher costs, and poor glycemic control in medicine and surgical patients, are associated with length of stay. And the increased length of stay, longer length of stay, is associated with high costs. But it's not only in those patients, but those patients, 17 million people in the emergency room who come with hyperglycemia are also at risk of more complications. For example, those patients poorly controlled have 10 to 15-fold increased rate of lower extremities amputations. And when these patients go home, we need good care. Educate the patient, educate family members, and link the inpatient with the outpatient setting to prevent hypoglycemia. We recently reported that those patients who develop hypoglycemia during the last day of hospitalization has significant increased rate of readmissions. And hypoglycemia is an important cause of readmissions and, of course, complications when the patient go home. Next slide. This is why our team Glycare is pleased to support the Leapfrog initiative together with the American Diabetes Association on the recognized Leaders Program for inpatient diabetes care. I serve at the chair for these guidelines, that we had a large group of experts in diabetes formulating these Leapfrog recommendations to improve inpatient diabetes care. These recommendations followed the initiative from CMS in 2022 that reported or suggested to report what we call hospital harm. This is prevalence or severe hypoglycemia and severe hyperglycemia. Currently, it's not a mandatory for hospital to report harm, but in the year 2025, the electronic clinical qualitative measures now is going to mandate that we all have to report the severe harm, the lows, severe hypo, severe hyperglycemia, because we want to improve diabetes care. So we are grateful with the Leapfrog and ADA initiative, and Glycare is pursuing this improved glycemic control in the hospital, in order to decrease complications. Next slide. And it's not only complication, but I want you to pay the attention to the right side of this slide. In one hand, we know the increased length of hospital stay, but with the top panel is the healthcare expenditure in those patients with diabetes compared to non-diabetes, which is increased by 4-fold. And in the lower panel, on the lower graph, it's for each increase of 50 milligrams, just 3 millimole in patient who has cardiovascular disease, the hospital charges hospitalization costs are significantly increased. Because of these facts, next slide, the American Diabetes Association, and now followed by Leapfrog, has recommended improved inpatient diabetes care. In this year, 2024, the American Diabetes Association Standard of Medical Care for Diabetes recommends using a dedicated inpatient diabetes management team. We understand hospitals are busy, primary cares are busy, and dedicated inpatient diabetes care has been shown to improve glycemic care and decrease economic outcome in hospitalized patients with diabetes. Let me now invite Professor Gary Evans to follow me and present to you Glycare.
Thank you, Dr. Ampires. So Glycare is a dedicated glucose management team designed to enhance and improve glycemic and diabetes care in hospitals. We are in alignment with the ADA standards of medical care, applying this strategic approach in facilities. Next slide, please, Corleen. So Glycare service is an evidence-based population management program. Our teams are comprised of nurse practitioners that are specifically hired, managed, and trained by Glycare, and specifically trained for inpatient diabetes and glycemic management. They're supervised by Glycare's team, including our quality nursing managers and supervisors, as well as board-certified endocrinologists that review and sign off on all notes. I do want to emphasize one key point, because this is often brought up in the Q&A. When a hospital already has an endocrinologist on campus, we prefer and actually enjoy working with them as being part of this service of reviewing and signing off on the notes and working with us as consultants. Our providers are responsible for glycemic management of all adult patients with diabetes, with some exceptions being ICU, obstetrics, and pediatrics. Our team is on campus 365 days a year, generally during daytime hours from about 7:30 in the morning till about 5:30 in the afternoon, or until the work is done. But we do have a 24-hour hotline, both during the day as well as after hours, so that any glycemic issues or orders or insulin orders that may arise get channeled directly to our on-call person covering the facility. This does address a burden that hospitalists are happy to be relieved of. We are happy to take and field all the glycemic related phone calls after hours and certainly during the day. Over to the right, it's important to emphasize that the inaccurate use of insulin in hospitals has led to its classification as a high-risk medication. Our approach to care by our team is literature-based and protocol-driven, so consistent application of accurate insulin delivery assures that we can reduce the risks of utilizing insulin within the facility. Our team and approach to care is evidence-based, and it offers facilities a cost-effective solution with numerous benefits and cost savings for the facilities, including reduced lengths of stay, reduced 30-day readmission rates, reduction in medical errors, and then also reduction of staffing and overhead cost. We are much more than simply a standardized order set. We are not AI, we are not a software product. We are a team of nurse practitioners that are boots on the ground. All patients are seen face-to-face each day. Our daily assessment creates sustainable, system-wide, meaningful quality improvements, as well as offering the facility the ability to establish one standard of care, which is critically important, and also independently reduces error rates within the various programs within the facility, pharmacy, hospitals, nurses, and so forth. So really the takeaway is that Glycare, we adopt a proactive, preemptive approach to patient care. And in doing so, we focus on preventing a problem rather than reacting to a problem or blood sugar abnormalities after they have occurred. So this proactive approach really helps us reduce the risk of complications related to high and or low blood sugar. And as Dr. Ramirez was alluding to, those issues can include infections, wound healing, cardiovascular events, and also serious safety events. Next slide, please. So for hospital patient care improvements that can be realized and are being realized by our Glycare team is that we're able to lower the average facility blood glucose significantly, and critically important, at the same time, reduce hypoglycemic events. Dr. Sutton will touch on this data in much more detail, but we've been able to reduce hypoglycemia anywhere from 25 to well over 50% for both mild, moderate, and severe. Also, we've been able to achieve a dramatic reduction in medical errors and safety events related to errors in diabetes management. And critically important, a dramatic reduction in the lengths of stay. And this is a very tangible financial benefit for the facility. On average, we've been able to reduce the lengths of stay by over 1.5 days. Also, reducing readmission rates by anywhere from 30 to 35%. And the benefits that we are achieving effectively minimizes unfavorable variations in clinical practices of hospitals and diabetes and glycemic management across all departments. Again, we're able to define one standard approach to care, so you see consistency and accuracy in applying insulin dosing. So as I mentioned, we're able to help the facility achieve very tangible financial benefits. This is an estimate based on an average 750-bed hospital. And this number was actually derived at just based on the reduction in length of stay alone. This does not account for the financial tangible benefits that are achieved by reducing readmission rates, reducing patient harm events, and errors. I should also mention that the services that we provide on campus are at no cost to the facility. We ask for no subsidy. We simply provide our service and bill at the mid-level reduced rate and directly bill the patient's insurance. Again, no cost to the facility for our being on campus. Next slide. So the mechanics of how Glycare works within the facility, number one, we identify the at-risk population. So our clinical criteria define that population and then embed clinical criteria into the EHR system to identify and place the consult automatically. Those criteria include glucose values above 200, patients that are on any anti-diabetic medication, both orals and or injectables so that the consult is placed immediately upon admission to the facility. Number two, the inpatient glycemic management. The three critical parts of this process are: number one, transitioning the patient and translating their outpatient regimen into the inpatient arena to use standard of care basal bolus insulin to maintain target glucose range of 140 to 180 during their hospital stay. This is a critical part, and this is where many mistakes otherwise have and could be made, is not applying the accurate transition into the hospital, and then not applying the appropriate adjustments on a daily basis. And then thirdly, the discharge planning, translating what they were on in the hospital back for their outpatient arena and management. So the patients are seen face-to-face by our team. The treatment is adjusted based on multiple clinical characteristics, including severity of illness, hyperglycemia, other disease complications, what their prior treatments were, do they have any cardiac or renal impairment, and so forth. So a lot of different factors go into translating in, adjusting during, and then transitioning back out of the hospital. And then number three, diabetes discharge planning is a critical part of the efficiencies that we provide for the facilities. Discharge planning begins at the moment of initial consultation is essentially our mantra. So from day one, we're already thinking through, does there need to be a significant adjustment of their outpatient transition? Were they on oral medications with an A1C of 9.5, where clearly they're going to require some insulin therapy as part of their outpatient transition? Our team takes care of all of the medication discharge med reconciliation. We take care of all the prescriptions for diabetes-related products, supplies, and prescriptions for medications. So that paves the way for a very quick and very efficient discharge process. And then number four, we maximize glycemic control with collaborative care. We take a team approach, working hand in glove with all the various disciplines within the hospital, not only the hospitalists, nursing, dietitians, case managers, pharmacy, diabetes education, as well as discharge planners, with the ultimate target of maximizing glycemic control to the patient's benefit. Outside of our focus on glycemic management, the usual patient care interactions remains with the hospitalist, of course. Next slide, the Glycare advantages and benefits across the health system. Number one is timescale. Because of the clinical criteria that then automatically cause the consult to be placed, our team is on the case generally on day 0. So it allows for us to have a very early impact on the quality as well as the lengths of the stay, and allows us to have a significant reduction in LOS. So again, it's a quick intervention. It really is the catalyst for population management efficiencies at a hospital level. Number two, workflow optimization. Our team augments the nurses and hospitalists by, again, focusing on and managing the glycemic care for patients. We standardize the care across departments and personnel, again, applying one standard approach to care for the facilities. And also for the facility, we make available our proprietary interactive dashboard, which provides key performance indicators directly sourced from the EHR system. Number three, again, going beyond surveillance, we monitor for various glycemic harm events, sugars above 300 or less than 70, and this allows our team to do a little bit of investigative digging, looking for a root cause analysis, which helps avoid complications and serious safety events that could have been avoided. Dr. Sutton's going to touch on this in a little bit more detail. And then number four, speed, simplicity, and scalability. Our approach to care helps reduce the non-beneficial variations in clinical practice as well as spend. Our value is that we focus specifically on the diabetes controlled. And again, our team is a team of nurse practitioners that, again, we take care of hiring, managing, and training them, as well as supervising them on the facility. Again, our billing is a fee for service. We do not charge the facilities for our services. And again, our charges are at a mid-level discount. And then our next slide is my favorite slide of our slide deck and is the reason that Glycare came to be. So with that, I'll go ahead and turn things over to Dr. Sutton.
Thank you, Dr. Evans, and thank you, Dr. Imperez. And this indeed is really the most important thing. I'm going to share with you data regarding multiple facilities on a macro scale, but this is looking at a micro scale, that is an individual patient. And that if something untowards were to happen to an individual patient in the world of diabetes, it could actually be a serious safety event or a life-threatening event. And indeed, we were called into action back in 2016 at a hospital where they had an unfortunate error due to mismanagement causing severe life-threatening hypoglycemia. And that's how Glycare was started. Prior to the initiation of Glycare at that facility, there were approximately 2 serious safety events regarding diabetes management and mismanagement reported every month. Once Glycare was initiated at this particular facility in 2016, up to today, there have been zero.
Oops, I think we lost him.
Enter into. And the reason for that is because we are constantly applying the standard care of clinically proven medical benefit.
Dr. Sutton, your connection is a
Style.
bit
So
weak.
everybody at the facility receives the same level of care, the same management for their hyper or hypoglycemia, which ultimately results in reducing nursing errors also, because now nurses are getting the same answer for common situations such as NPO status, such as patients on tube feed, such as patients that are dialysis patients. And this consistent management spread across a population reduces not only medical mismanagement, but also nursing errors. So serious safety events can be greatly improved upon. And this alone is a reason to adopt a diabetes management team, Glycare, because this can be seriously significantly reduced. Next slide, Pauline. So how do we track? Well, we do a root cause analysis on every case of hyperglycemia above 300 and hypoglycemia below 70. And what we do is we try to apply the cause of this hyper or hypoglycemic event. So as you can see over here on the right, when we do a root cause analysis, for instance, on hyperglycemia, we try to attribute the cause. Was it IV steroids or PO steroids or IV fluids, D5, D10, TPN? Is it a brittle type 1 diabetic who's had diabetes for 30, 40, 50 years? Or the unknown reasons? And the same for hypoglycemia. Was it due to NPO status, dialysis, brittle diabetes, etc.? And by applying this root cause analysis, we can start to eliminate systematic errors at a specific facility. For instance, we noticed that one particular floor of one particular hospital was having recurrent hypoglycemic events. And upon doing the root cause analysis, it was determined that this particular unit had a lot of dialysis patients. And believe it or not, these dialysis patients frequently would receive their morning sliding scale, their morning insulin dose, and oftentimes were whisked off to dialysis before they were able to eat their morning meal. So, of course, it was resulting in a systematic experience of hypoglycemia at that particular unit. Simply changing the workflow of that unit was instrumental at reducing hypoglycemia at that one hospital single unit. So this is what root cause analysis can help identify. Next slide. Now, this is looking at the data from a macro standpoint. We already talked about serious safety events affecting an individual patient. Now we're looking at macro data. And when you look at macro data across a facility, and this is 784 med-surg beds, I want you to look at 2 columns in the data. The far right column is the baseline, And the far left column is the Glycare following column. And you can look at, for instance, the top line there, average blood sugar at the facility. We, across all of our facilities, have seen improvements in every glycemic measurable. You can look at hypoglycemia, hyperglycemia, average blood sugars. Let's look at average blood sugars first. And we consistently see an improvement of about 20 to 30 points across a population at a facility. Now, on an individual basis, a 20 to 30 point improvement of average blood sugar may not be material, but across a facility where you're talking about thousands of patients, in this case, 9,000 patients at baseline and 4,900, almost 5,000 patients in the Glycare following group, you can see this is an across-the-board population improvement of overall blood sugar values. Looking at harm events, for instance, blood sugar days above 300, you can see prior to Glycare, 20.47%, reduced to 13.41% during the Glycare following period. That is about a 30 to 40% improvement. Looking at hypoglycemia, in this case, severe hypoglycemia defined as less than 40. This is one of the reportables that Medicare is going to be tracking. You can see a significant improvement from 0.94 at baseline to 0.34. That's a 2/3, 66% improvement of severe hypoglycemia. You can also look at readmission rates during the 30 days following discharge. Now, this includes all reasons, not just diabetes for the reason for readmission. And you can see a substantial improvement there also from 6.3% in patients at baseline to 3.6% at the Glycare following period. So about a 50% reduction of readmissions. Next slide, Corleen. And this is interesting because it looks at how rapidly these changes occur. If you look at the panel at the upper right corner, you can see what happens at a facility once Glycare is initiated. So in this particular facility, the baseline is shown in gray or black, and the Glycare data is shown in blue, the graph. And you can see once we entered this particular facility in August, you can see a rapid improvement by September and another rapid improvement by October as we rolled throughout the entire facility, whereby that 20 to 30%, 20 to 30 milligram per deciliter drop of blood sugars on average was realized. Again, as we initiate into a facility, again, you can look at hyperglycemia, reduced in this case from 20.85% to 12.22%. Severe hypoglycemia, again, reduced by 0.85 to 0.3%. That is about a 2/3 reduction of severe, potentially life-threatening hypoglycemia, as you remember from our initial calls into being as a glycemic management group. So this is some of the data. This data has been reproduced at every facility that we've initiated the Glycare program. Again, it's due to this constant application of American Diabetes Association standards of care across an entire population by very well-trained, hardworking nurse practitioners who apply this in a consistent manner. Next slide. So together we can eliminate some of the unnecessary diabetes complications for your inpatient population. We are happy to entertain any questions that you might have at this time, and please feel free to enter those into the Q&A portal.
Okay, I do have a couple of questions here. Let me see. A few of these pertain to insurance and how we bill for services. and the uninsured population. So is one of the questions, any type of insurance that we have trouble getting or getting compensated by, and therefore might affect the ability to serve the patient? I can probably answer that directly. It's we become par with the hospital's payers. We're going to treat all patients regardless of their ability to pay. The clinical criteria identifies a patient that we see, and so insurance is not part of our process. We do consider costs when prescribing as it relates to the patient's insurance, but that's not the one of the conditions for treatment if we are participating with the payer or not. And then, of course, we honor all facilities' charitable programs, and for the most part, with very few exceptions, if there is extremely high uninsured population, we typically do not ask for fees.
Yeah, and Corleen, let me just add as a corollary to that, because the consultation is triggered by glycemic indices that are embedded into the EMR, Glycare is completely non-discriminatory regarding financial abilities, regarding race, regarding creed, etc. It is applied in a population management regardless of means of payment across a facility. So it is the most non-discriminatory program that I'm aware of. It really approaches everybody in the same manner all the time.
It is consistent with the common goals of healthcare equity.
Absolutely.
Next question is around staffing. So do we use our own staff, or would it be possible to set up a program utilizing the facility's existing staff or existing structures? We can, maybe Dr. Sutton, you can speak, or Dr. Evans, you can speak to this, that we do work with, we work with the diabetes educators, the dietitians, things like that, and then just how our staff works within the facility.
Right. So our team, again, is comprised of nurse practitioners. We take care of hiring, training, managing them. So that part of the care team is what we provide to the facility. And then, of course, we work hand in glove with all the other disciplines, including the nurses, the diabetes educators, pharmacy, hospitalists, of course. But yes, so we provide the team itself within your market.
The CRMPs, are they on site, or could they provide care through telemedicine?
So our team is on campus. There are the boots on the ground. There are the hands and feet of the care that Glycare is providing to your patients at your facility. All patients are seen face-to-face each day, 7 days a week. In terms of the ability to do phone-related or virtual visits, so to speak, that is a possibility, and certainly we have done so at different facilities in various degrees. But in terms of as a general goal for within the facilities, we see the patients face-to-face to guide our daily management.
Right. We believe that daily human touch is necessary to provide communication. For instance, we are not a team of diabetes educators. We are a team of practitioners. However, we do some education, and that is oftentimes best communicated in person on a one-on-one basis. For instance, how do you handle your insulin as your steroids are being weaned? A common clinical problem that, if not handled correctly, can result in readmission rates and emergency room visits that are unnecessary, quite frankly. But this does require some degree of face-to-face communication, and we do provide that as part of our daily rounding.
Yes, and we can also provide care through telemedicine when, for example, if there's a sister facility that we can't particularly staff, or maybe because of the bed size is smaller, we could potentially see those patients through telehealth and other means. There's some nuances with that, so we would just need to know more about the facilities circumstances which would initiate the need for that telemedicine. Without having to go into too much detail, we can always talk that through. One of the questions, do you work with pediatric patients as well?
The
No.
answer is no.
Yeah, so really the only exceptions to our care provided would be intensive care unit, obstetric, and pediatrics. All other adult patients with diabetes and hyperglycemia are the patients that we provide care for within the facility.
And we have some ability in the intensive care unit. However, most of the hospitals that we have been associated with have their own intensivist and closed ICUs. So they really want to manage those patients themselves, but we are there for that handoff when patients leave the ICU and go to the floor, which is oftentimes a patient of a period of uncertainty in their care. We are there to assist with that handoff and make sure there are no gaps at all in their diabetic management.
Okay, because that brought me to what link is Glycare attempting to forge in order to transition the patient to the PCP office? Maybe you can talk about our discharge process.
Sure. So again, as I mentioned, the process of discharge planning begins at the moment of initial consultation. So we're updating and trying to assess what's the optimal transition regimen, what treatment plan for when they are discharged. Number one, we like to have the patient have close follow-up with whichever physician is managing their diabetes, whether it's a primary care or an endocrinologist, have close follow-up. We are not an outpatient treatment program, but we facilitate making sure we reinforce the importance of that patient to follow up with their care provider. The discharge med reconciliation, again, we take care of all that, all the prescriptions and supplies, and those instructions are carried with them when they follow up with their primary care physician.
Right, we prescribe, typically prescriptions are for 30 days and no more than 30 days. And they're discussed with the patient, of course, and we do ask them to see their PCP within, like Dr. Evans said, 30 days, or endocrinologist if it's they have an endocrinologist, typically within that 2-week to 30-day time frame.
And we take ownership in the medical reconciliation and the DPART process for diabetes, of course, just specifically for diabetes, because oftentimes that is frequently a stumbling block that patients run into when they leave the hospital facility, and that is the initiation of their outpatient medicines, when to initiate or when to change those medications appropriately. So we also handle that, and we have protocols in place for handling the DPART and the medical reconciliation.
So one of the questions, is there a minimum or maximum number of beds you're able to contract with? Typically, the bed count of a facility would be right around at least 250 in order for us to staff the in-person boots on the ground. But if there's a hospital system that has multiple facilities and they're, within a reasonable distance of each other, 20-30 minutes apart, that's a much easier staffing model for us to be able to have those boots on the ground specifically. But there isn't a maximum number of beds or clinics. We staff based on the facility's bed count, routine service beds. So we typically would say we would see about 30% of that population on a daily basis. And then we take from that, we would say each practitioner would see anywhere from 25 to 30 patients a day. And that's how we calculate how many practitioners we would need. We're in the hospital 7 days a week, 365 days a year. So we typically will have that staffed in 2 teams, working the first half of the week, second half of the week, and then alternating weekends.
And so the short answer is yes, we have experience at small as well as medium, as well as large facilities, anywhere from 200 to 600 plus beds, and generally about 200 plus is the minimum that we would require to staff. But again, as Corleen mentioned, if there are satellite facilities where we can basically make it a combination, we can generally make that work.
Are all your NPs familiar with the different EMRs, Epic, Cerner? Definitely, yes. Yes. Yes, I can say all EMRs. Yep, we are familiar with just about every EMR. There is no integration. We have no tools, devices, anything that would have to integrate into your EMR. So your IT team would be, cybersecurity folks would be very happy about that. The data that we receive from the hospital is sent to a secure server. It's just a flat file with some data elements that we would need in order to do our billing in fee for service at the mid-level reduced rate. Other than that, we would capture data, clinical data on the patients that had the Glycare consult and then aggregate that. But that's all done through file sharing through a secure portal. There's no integration into the EMR. And yes,
we have experience with some of the larger players in the EHR market, including Cerner, Epic, Meditech, Sunrise. So we've been able to successfully integrate what we do and how we do it within the various EHR systems.
What is a typical lead time when signing an agreement with Glycare for the program to be up and running at a facility?
Typically 120 days or 4 months. That allows us to get all of our staff privileges at the facility. That independently, just in and of itself, may take 2 to 3 months to get everyone with privileges, and then also provides us with an adequate lead time for our hiring and the training that's required before they set foot in the facility.
Okay, let's see. So if a facility already has some providers that are doing these type of activities, would your company replace them with your own people? So that we're not, so there's some caveats there. Since we're not going into, we're seeing routine service, so med-surg step-down units. Maybe you could define what you mean by already have other providers. So we can answer that a little more clearly. It depends. I mean, our nurse practitioners, if we're seeing 30% of a facility's bed count on a daily basis, that's going to be, quite a few patients, anywhere from 70 upwards on a daily basis, from admission to discharge. So maybe if you could clarify that, we can give you a more specific answer.
Sure. Perhaps just touching on what I think they're asking is, what if they have an endocrinologist on campus that sees endocrine consults, some of which are diabetics, ICU, and so forth. And generally what an endocrinologist sees in the facility is very much the tip of the iceberg. It's what's below the water's surface is the facility's challenging problems. And that's what Glycare addresses. We basically see virtually all the patients with glycemic issues. If you have the luxury of an endocrinologist on campus to see those patients that are in the ICU and so forth, we often work very nicely with them. But in terms of replacing a team, we wouldn't replace a team if you already have a team. That would not imply the needs for our service. But in terms of what we do and how we do it, we think we are leaders in this arena for really applying, again, literature-based, consistent, accurate care.
Yeah, and
Right.
if you happen to have at your facility nurse practitioners that are seeing diabetic patients and have diabetes experience and expertise, by all means, we would love to attract that talent to the Glycare team. So we would certainly want to interview them and bring them on board with, of course, utilization of our protocol and our management style. But we would love to integrate them into the Glycare team.
Right, and can you, Dr. Evans, maybe describe if somebody, the type of patient, the patient population that we're treating, we're not necessarily treating because they were admitted due to their diabetes or admitted for other causes. So how would that work in relation to some of these, like the endocrinology groups or some of these other teams?
Well, again, the subset that the endocrinologists are seeing is just that it's a very small subset of the total hyperglycemic population. What they have not been seeing is who we would be seeing, which is statistically about 25% of the hospital's inpatient population.
Yeah, if you look at the number of endocrinologists, I don't need to remind anybody, I'm sure that there's a critical shortage of endocrinologists. It's if you have an endocrinologist at your facility that is still going to the hospital, that is a rarity today. 80% of endocrinologists do not go to hospitals. They only stay in the outpatient arena and do not practice in the hospital. But if you happen to have one that is in the facility, we would certainly work with that individual to the best of our abilities. And they would certainly still be seeing their share of endocrine patients, as well as some of the more complicated diabetics we would send to them. But for most part, this is not the scenario. The scenario is lack of endocrinologists.
Right.
Right.
And as I mentioned before, we very much, again, if your facility has an endocrinologist, we very much like working with them as part of our team, being consulted as the individual for chart review and sign off on notes and so forth, so that they're part of this solution that we're helping the facilities to achieve.
Right, and remember, we're treating the population, so that is going to be a lot of patients for that endocrinologist to be seen on a daily basis as we are to the level that we're treating them. If the facility has some clinical pharmacist monitoring and intervening that way, how would you suggest that Glycare? How would Glycare be helpful to that extent that we could relieve some pharmacist monitoring and intervening duties?
Yeah, well, first off, we would work hand in hand with the pharmacist, and we do on a daily basis. But the difference is Glycare is in the patient rooms on a daily basis by a team of practitioners who are trained not only in pharmaceuticals, but also in the complete management of the diabetic state. So you have practitioners in the room working hand in hand and in conjunction with your existing teams. And
through that process, and because we do that root cause analysis, we're able to identify many preventable events that just couldn't be identified otherwise, right down to a specific unit, a floor, a shift, night or day, and we're able to address. And again, these aren't necessarily all medication errors, right? This could be timing of when services were actually provided to the patient, or just bringing nursing up to speed on when to call based on clinical scenarios that would affect the patient negatively. You know, having that practitioner there in person and creating that one standard of care.
And I think that
many of these issues.
The communications that we have, and I think this is really a very important part of what we also bring to the facility, is our experience and how to apply a consistent pharmacy standard of care, so that we help the pharmacy refine the formulary goals to narrow it down. We work within the formulary of the facility, but again, we enjoy and look forward to working with the pharmacists and making sure that the formulary is adjusted to allow us to provide the most accurate care within the facility. Those are things as simple as basal insulin that's being utilized, what bolus insulins are being utilized, and so forth.
Do you utilize clinical pharmacists that are specialized in glycemic management?
Well, they're not part of our team. Our team is comprised of nurse practitioners. But certainly if there's a pharmacist that has that background at a particular facility, we would want to engage that pharmacist and work with them.
Let's see if I missed anything in between. Do you support patients after discharge?
So we pave the way for their transition back into the outpatient arena, but we do not have a outpatient clinic per se. So we facilitate and recommend their follow-up with whichever clinician is providing their outpatient care, whether it's their primary care physician or an endocrinologist, but that is the outpatient arena follow-up.
Is the service base on a contract? You have a contract.
Corleen?
Yes, we do have a medical service agreement. They're outlining our role in the hospital as a diabetes population management service for that facility. Let's see. Okay, in hospitals, you currently staff, are they automatically referring patients to the program as a matter of protocol from the ED, or if they have a diabetes diagnosis, or is it handled individually? They're one of the
So it's
that the doctors could be protective over their patient populations, and what's the best way to handle that?
Sure. So that's one of the challenges in bringing change to a facility is the understanding of why it's being implemented. The status quo of diabetes care has a lot to improve upon, and it's been shown in the literature over the past well over 10 to 15 plus years now that when you utilize this strategic approach to care, a dedicated glucose management team, that you absolutely enhance and improve the overall glycemic outcomes, clinical outcomes, and economic outcomes for facilities. So it's important that the medical staff community as well as the administration is working together to achieve compliance with this approach to care. So opting out leads to more than one standard of care within a facility, which can be problematic. So to enhance accuracy and precision of the care that's delivered, this strategic approach to care, it's important that it's a facility-wide process.
Yeah, I think it's very important, especially because we really are population management. So like Dr. Evans mentioned, if you have physicians that want to opt out, you don't get population management anymore. You don't get this consistency of care. And as he also managed multiple published articles now showing that this diabetes team approach at a facility greatly enhances diabetic care, diabetic measurables at all facilities with results similar across facilities to what we have seen across facilities. So it is really a consistent finding that glycemic care is improved system-wide.
Will your staff also manage insulin pump patients?
Yes, we do. They are trained in insulin pump management and manage those patients in-house. If patients are able and willing to manage and operate their pump, we typically do let them operate their pump. So self-management in the hospital with, of course, supervision and observation. But if they are incapable or unwilling, of course, we transition them off the pump in the hospital.
Okay, thank you. How many health facilities, health systems are you currently working with?
Corleen, you want to?
I believe we're up to about 14.
Yeah, I think that's right.
What is the There's a question about the hypoglycemic parameter trigger, so generate the glycare report referral. Okay, can you explain how the IP process works for the clinical criteria that's embedded in the EMR?
Sure. So the main criteria that prompt the system to create the consult and place the consult is 2 glucose values above 200, the presence of pre-admission anti-diabetic medications, both orals as well as injectables, hypoglycemia, and an A1C of 8.5 or greater. So those are fairly straightforward and easy for us to create and embed within the EHR system, working with your IT, and it's something that's fairly easy. This is not a long-term project to make it happen. It's pretty straightforward and simple.
And so, what, as part of this question, is this also a clinician-generated request? So it can be done actually 2 different ways. You have the clinical criteria that identifies that the patient. If the consult can be done automatically, that's ideal because we're immediately on the case without having somebody having to actually physically input the consult order. But we have had instances where the patient populated on a list, right, within the EMR, and then the nursing staff would generate the consult order after seeing that patient trigger through that list. So it can be done a couple different ways. Hopefully that answered the question, yeah. Do you see improved patient outcomes as protocols are updated in line with new clinical guidelines?
Can you repeat that, Corleen?
Do you see improved patient outcomes as protocols are updated in line with new clinical guidelines?
Yes, well, the care that we provide, we stay up to date with all the clinical guidelines, standards of medical care, American Diabetes Association standards of medical care for inpatient management. So when any of those updates occur, we're on it and up to date. And all of our staffing is also updated in that regards.
I think we're at the time limit here.
Yes, just a question, one last question here. Do you have a process for working with different formularies, particularly in different formularies for multiple insurance companies? And then
so the quick answer for that is we try to, number one, always provide the patient with a cost-effective care plan. If they don't have insurance, we'll make sure that we give them a prescription for the Rely On type brands that are tremendously discounted at Walmart. And then for those that do have insurance, we try to stay within their formulary as best we are able, so that that also lowers the cost for them.
Yeah, that's an important part of the training process that the practitioners go through.
And as part of this question is, tri-state hospitals in a corner state that will draw patients from 3 different states, basically working with patients where the payer's not their in the home state. So yes, we're super familiar with that. That's not a problem, and we certainly can work around that. As business as usual for us in that regard. Can you, one of you, speak to really quickly the level of training and for the nurse practitioners before they even actually see a patient?
Sure. All of our team goes through a very intensive, rigorous training program called Glycare University. It's an interactive online platform that throughout our core syllabus, as well as over 150 actual case reviews and walkthroughs, by the moment they set foot in the hospital, they are well familiar with virtually every clinical scenario and approach to care that they will encounter in managing patients from the moment they start. Also, there is continued quality review by our quality nurse management team. And then, as I mentioned, overlaying layers of quality supervision. All notes are reviewed 100% for the first 2 months by our quality nurse management, and then an ongoing meaningful sample, and then 100% of their notes are always reviewed by the endocrinologist and signed off. And Corleen, I think, Corleen, we're within our time constraints that we have to wrap it up here.
Yes, I was going to share one last thing. I shared my screen here. This is glycare.com. If you go there, we do have, and scroll down, there are some frequently asked questions. I think that might be helpful for anybody that has residents and interns, endocrinologists. What are the implementation costs at your facility? You'll be pleased to see. We are responsible for overhead. We don't ask for subsidies, see all patients regardless of their ability to pay. So there's a lot of the common questions here that we can answer. And then I can also provide my email address in the Q&A piece here. If anybody has some questions, they can email me directly. But we definitely appreciate everybody's time. Thank you for joining us. I hope you found this informative. And now know that Glycare is a resource that exists, and we would love to talk more. Thank you, everybody. Have a fantastic
Thank
rest
you,
of your
everybody.
day.
Thank you. Thank you, everybody.